and
Yeah,
good
thank
morning.
you. Yeah.
Yes, sir. This is the one.
Yes, sir. You can start, sir.
1000 homeopathy. Yes, sir.
Yeah, you can start.
Today,
Sir.
our guest is Dr. Sajan. Yes, sir. There is some. Let us begin the session with 1 minute silent prayer. Thank you all. The International Forum for Promoting Homeopathy comprises of homeopathic lovers, students, and doctors. We have 3 sessions every day, and the first session of the day is already over in Hindi from 7:30 to 8:30. And from 8:30 to 9:30, we have the international session in English, and from 9:30 to 10:30, a local language session in Malayalam. All these sessions are going in a good way, and we are uploading the videos of the same on the very next day itself. So let me come to the today's guest. As you know, that today it is Dr. SAJAN V. EDISON. He has completed BHMS from Trivandrum Homeopathic Medical College from the government sector, and now doing MD in pediatrics at White Memorial Homeopathic Medical College, Tamil Nadu. And doctor will be talking about benign prostatic hypertrophy and its homeopathic management. We proudly welcome the guest of the day, Dr. SAJAN V. EDISON.
Sir, is it the slide is
Yes, visible. It is visible.
okay. Okay, thank you, sir, for the wonderful words. First of all, very warm good evening to every doctors who are gathered here. Myself, Dr. Sajan, completed BHMS in the Government Homeopathic Medical College. Now ongoing PD, MD in pediatrics in White Memorial Homeopathic Medical College. First of all, I would like to thank the whole International Forum for Promoting Homeopathy faculties and their management team for giving me a wonderful opportunity to present a small session in such a wonderful Zoom session. It's a great honor, and thank you everyone for giving me such an opportunity to present in a global forum, especially my senior doctors. All are there. So once again, thank you all. Okay, can you see the slide? First page?
Yes. You can go ahead.
Okay. Today's topic is benign prostate hyperplasia. As a homeopathic doctors, we are familiar with the cases of benign prostate hyperplasia. In nowadays, it's a common presentation seen in our clinic. So, in today's session, I would like to share some of the basic sessions of the basic anatomy and physiology and everything of the prostate and their symptoms and their clinical presentation and investigations and the therapeutic session of the benign prostatic hyperplasia. Okay, first of all, about the anatomy of the prostate. The prostate is a globular fibromuscular gland that surrounds the prostatic urethra, which is 1.25 inch or 3 centimeter long and is surrounded by fibrous capsule, and its base lies against the bladder neck and apex lies against the urogenital diaphragm. You can see the picture of the bladder and showing the prostatic gland just below the bladder, and there are two seminal vesicles, two ejaculatory ducts. These are the lobes of the prostate: anterior lobe, the posterior lobe, median lobe, and lateral lobe. Usually, the primary CA usually arises from the posterior lobe, and adenoma usually arises from the median lobe. Benign prostatic hyperplasia is a benign enlargement of the prostate which occurs after 50 years, usually between 60 to 70 years of life. There are two components of the prostate: epithelial cells within the gland and stroma with the connective tissue and smooth muscle. BPH affects both with the proliferation of epithelium and connective tissue stroma. You can see the picture of the normal prostate and also compared with the enlarged prostate in the right side. You can see the picture that the enlarged prostate compressing the urethra. And usually the prevalence of benign prostatic hyperplasia affects usually after the age of 50 to 59 age of life. And also we can see the increase in the number of cases of advancing ages day by day. Usually in the ages of 70 plus, there is more number of cases is seen. And when we discuss about the risk factors for the benign prostatic hypertrophy, the age, the number of cases increases with the increase in age, and about the race, usually decrease the risk of clinical BPH in Asian compared to the white men. And physical activity increases physical exercise, decrease the risk of BPH. So inactivity may lead to benign prostatic hypertrophy and metabolic syndrome, hypertension, dyslipidemia, glucose intolerance, central obesity, and when we come to a small studies, the annual prostatic growth rate increased by 45% with the type 2 diabetes mellitus and 17% with the hypertension, 36% in obese men, 31% with the low levels of HDL cholesterol, and 28% with the high levels of fasting insulin. So these are the risk factors that may lead to BPH. And when we discuss about the diet, a significant increased risk of BPH was shown with the frequent consumption of cereals, bread, eggs, and poultry. Studies suggested that low occurrence of BPH in Asian men as well in vegetarian men can be attributed to low fat and high fiber diet. And when we discuss about the pathology, BPH usually involves median and lateral lobes. As I told earlier, the normal anatomy of the prostate and the lobes of the prostate, where BPH usually involves in median and lateral lobes or one of them. It involves adenomatous zone of the prostate, submucosal glands, and when the median lobe is enlarged, it enlarges into the bladder because median lobe is below the bladder. So if the median lobe enlarges, it enlarges into the bladder and compresses the bladder. When it comes to the lateral lobe, it narrows the urethra and causes urinary obstruction. So it's very important to understand that median lobe enlargement may lead to the bladder compression, and the lateral lobe may lead to the narrow of the urethra and cause obstruction. The bladder initially takes the pressure burden, causing trabeculations, circulations, and later diverticula formation. Enlarged prostate compresses the prostatic venous plexus, causing congestion called as vesical pilus, leading to hematuria. This is a BPH bladder morphology. You can see the hypertrophy of the wall, the trabeculation. You can see the median lobe protrusion, the prostate enlargement. Everything is covered in the picture. Kidney and ureter back pressure causes hydroureter and hydronephrosis. Secondary ascending infection causes acute or chronic pyelonephritis. It may lead to acute or chronic pyelonephritis. Often severe obstruction can cause obstructive uropathy with renal failure, and also BPH causes impotence also. So now we are going to discuss about the clinical features of the benign prostatic hypertrophy. When discussing about the symptoms of voiding, hesitancy, poor flow, not improving by straining, because the urine flow is not improving by the straining, and hesitancy, dribbling even after urination. When we urinate also, there is again dribbling of the urine happens, and intermittent spasm, stop and starts, poor bladder emptying. It may lead to again have the sensation to urinate again and again, and episodes near retention. And about the symptoms of storage, there is increased frequency, nocturia, urgency, urge incompetence, nocturnal incompetence are also present in benign prostatic hypertrophy. Impaired bladder emptying with its problems like cystitis, urethritis, stone formation, and residual urine. And also, it may lead to hematuria also. The prostatism, frequency both day and night, poor stream, delay in starting, and difficulty in maturation. And also, there is palpable enlarged bladder on chronic retention. Hydronephrotic kidney is palpable. And there is also symptoms of UTI, fever, and chills happens when there is urinary tract infection also. It may lead to UTI. And these are the important clinical presentation symptoms that can be formed when there is a benign prostatic hypertrophy. In this picture, you can see the enlarged prostate causing the narrowing of the ureter, and there is residual urine. The right side picture, you can see the residual urine collecting due to the narrowing of the urethra, and there is thickened bladder also. These are shown depicted in the picture. Then coming to the investigation part, urine for microscopy and cultural examination is done, and USG is done. The presence of any residual urine we can assess, and the transrectal ultrasound help to find out any nodules or CA prostate. So, but it is not done routinely. So, IVU to see the kidney function, and PSA is assessed, acid phosphatase, blood urea, serum creatinine. These all are assessed in the case of suspected case. And also urodynamics, the urine flow rate above 50 milliliter per second is normal, and less than 10 milliliter is low, and 10 to 15 ml is equivocal. And about the voiding pressure also, below the 60 centimeter of water is normal, and more than 80 ml is high. 60 to 80 ml is also equivocal. Okay, so in the investigation part, mainly we are assessing these things, importantly PSA, acid phosphatase, blood urea, serum creatinine, and urine microscopy, and USG also it is performed. And about the prostate specific antigen, PSA, the prostate specific antigen, and acid phosphatase. In case of prostate specific antigen, produced from prostatic epithelium, the normal value is 4 nanogram per milliliter. More than 10 nanogram per milliliter is significant in CA, and more than 35 ml is diagnostic in advanced CA of prostate. PSA elevation not only in carcinoma but also in hyperplasia and prostatitis. This PSA, prostate specific antigen, which is produced from prostatic epithelium, is increased. Men above the 50 with PSA more than or equal to 3 should undergo biopsy. Then coming to the acid phosphatase produced by prostate, and the estimation should be done on empty stomach because heavy meals should alter the level also. So it should be done on the empty stomach only. Normal value is 0 to 5 Armstrong per 100 ml of serum. Not increasing BPH, it is raised significantly in CA and metastasis. Slight increase in acute prostatitis. So clinically, the perirectal examination is shown in this picture. The perirectal examination is also done. The picture is shown about the normal prostate and prostate cancer. There is a compressed urethra. We can see the thickening of the bladder, enlarged prostate. Everything is shown in this picture. And then coming to the differential diagnosis of BPH, the first one is the prostate cancer. In case of old age, enlarged lymph nodes in abdomen or supraclavicular fossa, digital rectal exam, cancerous heart nodules, median sulcus obliterated, non-mobility, rectal mucosa or enlarged prostate. This all leads to prostate cancer. And the next one is the prostatitis. Then fever, burning sensation, increased frequency, purulent vaginal discharge, rectal examination, tender and enlarged prostate leads to prostatitis. UTI, urinary tract infection, is also another differential diagnosis with increased frequency of urine both day and night. Urgency, dysuria, hematuria is also seen. There is WBC and ESR level is also increased. Then CA bladder, painless hematuria, first and common symptom, and then increased frequency, urgency, burning sensation, pain on pelvis region. The next one is the urethral stricture. The common cause of traumatic, mainly rupture of membranous urethra following pelvic fracture, diminished urine flow, also leads to the urethral stricture. Then coming to the general management, the management side, the general management is to urinate when they first got the urge. When we got the urge, first urinate is the first thing, and also to discontinue tobacco, the use of tobacco, alcohol, caffeine, especially after dinner, and not to drink lot of fluids at once, and avoid drinking fluids within 2 hours of bedtime. Before going to bed, within 2 hours of bedtime, try to avoid drinking fluids. And there is also in management system, alpha blockers are used. 5-alpha reductase inhibitors, preventing the hormonal changes that cause prostatic growth, and combination drug therapy is also there. Combination drug therapy is also there. The alpha blockers and 5-alpha reductase. Okay. Is it visible? The slide is visible.
Yes, sir.
Okay. And then in the allopathic system, they suggest for the surgical management. They would try to do the transurethral resection of prostate. Most common and popular surgical method is the the most common and popular surgical method in enlarged prostate is identified and is resected using the transurethral resection of the prostate. And when we discuss about the complications, in BPH complication, there is obstructive uropathy, and then to the bladder hypertrophy. If the BPH is not treated or not surgically intervened or not taken necessary management system, then it will lead to the complications of benign prostatic hypertrophy. So it may lead to the obstructive uropathy, may lead to the bladder hypertrophy, trabeculation, then diverticular formation. When the bladder is constantly compressed, it may lead to the diverticular formation and hydrourethra, hydronephrosis, lithiasis. Or stone formation. There may be a stone formation in the bladder, and also it may lead to the secondary infection. These are the complications. So we have briefly discussed about the basic anatomical structures, the lobes, and about the benign prostatic hypertrophy and its clinical presentation and its complication and general management and surgical intervention. All we have discussed now. Then we are moving on to the therapeutic section. In therapeutic session, when we repertorize in boric, there is a hypertrophy. It follows so many remedies, allow arsenal nitricum, like that it follows. And later we will discuss about the some remedies also we are going to discuss. So just briefly going through the repertorial part. In Kent, there is prostate gland enlargement rubric is there. In boric, urinary flow frequent. Then Kent, urging to urinate, night, boric, retention, Kent, bladder retention, old man, boric, scanty flow, drop by drop. And synthesis and Murphy's repertoire is also included in this slide. So now we are going to the homeopathic therapeutic part. So I just included some remedies and their indications to the benign prostatic hypertrophy. So the symptoms, indications, I just that only I included in the slide. So we can just go through some remedies and their indications. So aconitum napillus, urine scanty, red, hot, painful, tenesmus and burning at the neck of the bladder, burning in urethra, urine suppressed, bloody, anxiety always on beginning to urinate, retention with screaming and restlessness, and handling of genitals, renal region sensitive, profuse urination with profuse perspiration and diarrhea. Then alumina, urine, muscles of bladder, paretic, must strain and stool in order to urinate, pain in kidneys with mental confusion, frequent desire to urinate in old people, difficult starting, belladonna, urine retention, acute urinary infections, sensation of motion in bladder as of a worm, urine scanty with tenesmus, dark and turbid, loaded with phosphates, vesical region sensitive, incontinence, continuous dropping, frequent and profuse hematuria where no pathological condition can be found, prostatic hypertrophy, Berberis vulgaris, urinary, burning pains, sensation as if some urine remained after urinating, urine with thick mucus and bright red, mealy sediment, bubbling, sore sensation in kidneys, pain in bladder region, pain in the thighs and loins on urinating, frequent urination, urethra burns when not urinating, cantharis, urine intolerable ulcering and tenesmus, nephritis with bloody urine, violent paroxysms of cutting and burning in whole region, renal region, with painful urging to urinate, bloody urine by drops, intolerable tenesmus, cutting before, during and after urine, urine scalds him and is passed drop by drop, constant desire to urinate, membrane scales looking like bran in water, urine jelly like sheddy, and then Simophila ambulata, urinary, urging to urinate, urine turbid, offensive, containing ropey or bloody mucus and depositing a copious sediment, burning and scalding during urination and straining afterwards, must strain before flow comes, scanty urine, acute prostatitis, retention and feeling of a ball in perineum, unable to urinate without standing with feet wide upward and body inclined forward. Then equisetum hyemale, severe dull pain and feeling of fullness in bladder, not relieved by urinating, frequent urging with severe pain at the close of urination, when urine flows only drop by drop, sharp, burning, cutting pain in the urethra while urinating, intolerance in children with the dreams of nightmares when passing urine, much mucus in urine, albuminuria, and involuntary urination. Then ferrum picricum, urinary pain along entire urethra, frequent menstruation at night with full feeling and pressure in rectum, smarting and neck of the bladder and penis, retention of urine. Then calcium carbonicum, urine obliged to rise several times at nights to urinate, pressure on bladder long before urine comes, involuntary urination when coughing, sneezing, etc. Then creosotum, offensive, violent itching of vulva and vagina, worse when urinating, can urinate only when lying, cannot get out of bed quick enough during first sleep, dreams of urinating. Enuresis is the first part of night, must hurry when desire comes to urinate. Then lilium tick, urinary frequent urging, urine milky, scanty, hot. Nexomica, urine irritable, bladder from spasmodic sphincter, frequent calls, little and often, hematuria, ineffectual urging, spasmodic and strangulation, while urinating, itching in urethra and pain in the neck of the bladder. And then pulsatilla, urine increased desire, worse when lying down, burning in orifice of urethra during and after menstruation, involuntary menstruation at night, while coughing or passing flatus, after urinating, spasmodic pain in bladder. Then Sambucus nigra, urine, profuse urine with dry heat of skin, frequent menstruation with scanty urine. Then phosphoricum acidum, urine frequent, profuse, watery, milky, diabetes, menstruation preceded by anxiety and followed by burning, frequent urination at night, phosphaturia, prunus spinosa, urine tenesmus of bladder, ineffectual effort to urinate, hardly able to urinate, the urine seems to pass as far as glands and then returns and causes pain in urethra, neuralgic dysuria, must pass a long time before urine appears. Then Staphysagria, the pressure upon bladder feels as if it did not empty. Sensation as if a drop of urine were rolling continuously along the channel. Burning in urethra during menstruation. Prostatic troubles, frequent urination. Burning in urethra when not urinating. Urging and painful after urinating. Then about sulfur, urine frequent menstruation, especially at night, enuresis, especially in scrophulus, untidy children, burning in urethra during menstruation, lasts long after, mucus and pus in urine, parts sore over which it passes, must hurry, sudden call to urinate, great quantities of colorless urine, and uva ursi, frequent urging with a severe spasm of bladder, burning and tearing pain. Urine contains blood, pus and much tenacious mucus with clots in large masses. Involuntary green urine, painful dysuria, burning after the discharge of slimy urine. Causticum, urine involuntary when coughing, sneezing, expelled very slowly and sometimes retained. Involuntary during first sleep at night, also from slightest excitement, retention after surgical operation, loss of sensibility on passing. Clematis correcta, urinary tingling in urine, lasting some time after urinating, frequent scanty urination, burning at orifice, interrupted flow, urethra feels constricted, urine emitted drop by drop, inability to pass all the urine, dribbling after urination. Then conium maculum, urine, much difficulty in avoiding. It follows and stops again. Interrupted discharge, dribbling in ointment. Gelsemium, urine profuse, clear, watery, with the chillness and tremulous. Dysuria, partial paralysis of blood and flow intermittent. Opium, urine slow to start, feeble steam, retained. Retained or involuntary after fright, loss of power or sensibility of bladder. And heparsep, urine voided slowly without force, drops vertically, bladder weak, seems as if someone always retained, greasy pellicle on urine, bladder difficulties of ointment. And subalcerulata, urinary constant desire to pass water at night, emesis, paresis of Spinger, chronic gonorrhea, difficult urination, cystitis with prostatic hypertrophy, digitalis, urine continued urging in drops, dark, hot, burning, with sharp cutting of throbbing pain at the neck of the bladder, as if a straw was being thrust back and forth hours at night, suppressed, amenovical and turbid, urethritis, phimosis, stagnary, full feeling after urination, constriction and burning as if urethra was too small, brick dust sediment, lycopodium, urine pain in the back before urinating, ceases after flow, slow in coming, must train retention, polyuria during the night, heavy red sediment, child cries before urinating, and Barrett-Takar, male, enlarged prostate, diseases of old man, urinary, every time patient urinates, his piles comes down, urging to urinate, hydrangea, urine burning in the urethra and frequent desire, urine hard to start, heavy deposit of mucus, sharp pain in loins, especially left, great thirst with abdominal symptoms and enlarged prostate, gravely deposed, spasmodic stricture, profuse deposit of white amorphous salt, thuja, prostatic enlargement, urinary stream split and small, sensation of tickling after urination, severe cutting after, frequent micturition accompanying pains, disease sudden and urgent but cannot be controlled, paralysis, Spinger Viscae, Pareda breva, urinary black, bloody, thick mucus urine, constant urging, great straining, pain down thighs during the efforts to urinate, can emit urine only when he goes on his knees, pressing head firmly against the floor, feeling of the bladder being distended and neuralgic pain in the anterior crucial region, dribbling after menstruation, violent pain in glans penis, Res aromatica, hematuria and cystitis come with the range of this remedy, urinary incontinence, severe pain at beginning or before urination, constant dribbling. Then thiocinaminum are solvent externally and internally for dissolving scar tissue, tumors, enlarged glands, lupus, strictures, adhesions, hypertrophy of prostate is also indicated. So these are some remedies I have discussed. for the indications of the symptoms of benign that are similar to the symptoms of the benign prostatic hypertrophy. So we are about to conclude the session because I have some mentioned about the anatomy and the pathophysiology and the clinical symptoms of the benign prostatic hypertrophy and the complications and the management, both medical and surgical also we have discussed. So here I would like to conclude my session. So you can also say some suggestions about this session. Okay.
Thank you.
Okay, Dr. Sajan.
Thank you. Thank you. Let us close the screen sharing and yes, stop. Okay, no, 1 minute, please wait. Okay. Thank you, Dr. Sajan Edison. You really done a very good session for this benign hypertrophy of prostate with the management also. Anyway, we would like to have a session from you in the future also because your presentation is just like a professor, assistant professor doing some business. That's that kind of presentation. Anyway, congratulations for that. And this is one of the commonest problem nowadays. People used to come to us clinic, particularly people above 40 years are usually suffering from this problem. And there are many reasons behind it. Of course, the scientific reason maybe we are getting from the pathology books, but when we take the case in detail, we may find that there are several mental reasons behind the illness, and that may be the precipitating cause for all this stagnation. Whenever there is a stagnation, then naturally the organ may develop into a big size, big size, and it may produce a lot of damage to the organ and particularly the person. So that may be the precipitating cause behind. So it is the duty of a homeopath to find out the reason behind the illness, and then so you will have to sit with the patient for a long time to find the exact reason of the illness. And once you find the reason of the illness, then you can go ahead with the remedies you suggested in this forum. And definitely all the remedies are really useful as and when one apply the same with the caution. Usually then we have to do USG ultras as well as the CT scan or MRI for finding the exact reason for this size and this cause of the illness and what are the things that make this patient suffering from these things. Anyway, it's the time I invite those who want to participate in the discussion can join us and please raise. I think Dr. Indrani Bavatkar is already there to ask
Yeah,
some questions. Yes.
yeah. So, sir, am I audible? Yeah.
Yes.
Yes, but it was a very nice presentation. All remedies were very leading and very quite nice. A question comes to my mind. Many a times we see patients of benign prostatic enlargement having calcareous deposits accidentally found in sonography. So, sir, how to approach such cases and what are the remedies for that? Can you suggest them? Yeah, sir is online. Yeah.
Yes, here is. Frankly, Dr. Sajan is a junior person and just only a few years of experience and may not be able to give the answer into all questions. So
No
somebody.
problem. Some other easy one I will tell you. Sir, how should we take the PSA value? Because many a times what happens, the symptomatically the patient improves, but the PSA value doesn't improve in such patients. So like how much importance should we give? Can you kindly tell us?
Yes, Sajan, you want to say something? Yes.
Is it audible, sir?
Yes,
Yeah.
audible.
Sir, pardon, I didn't able to hear the
Question. What kind of importance one need to give to PSA value when even after treatment and the patient feels better, but still the PSA value is not coming down. In those conditions, what can be done, or what is your assessment on that conditions? This was the question. Anyway, can you hear me?
Yes, sir. Yes, sir. So, as homeopathy doctors, we should even in the progress when we first of all, some cases came in our practice life. Also, some patients come after the so much treatments and everything, and they are coming after lot of suggestion from other doctors and everyone. At last only they come to our clinic also. When they come also. If we give the medicines and as the doctor said earlier, so if the values are not come, that is the question, right, sir? If
Yes.
if the values are not come, actually, I told the doctor, the next doctor about because now only I passed the UG course and I'm seriously not able to give the suggestion about the that's
Yes,
why.
actually,
No problem. It's very kind of you. You have given a very nice presentation. No problem, sir.
actually, in those conditions, we just want to know whether the general conditions are improving and the patient's hemoglobin level and everything is maintained. Then you can, if the patient is happy, then you can ask the patient to continue the
Yeah.
medicine. It doesn't matter much, but if there are and if there is, if the patient find it very difficult to pass urine, he is unable to walk, he may be better, getting worse day by day, and still the PSA value is still there, and then you can think that the case is worsening and you need to change the remedy in those conditions. Of course, yes, either you may have to give some complementary medicine, or sometimes you may have to take the case once again. And there are certain hidden factors behind all these things. I have seen several times. One of my patient who has this much of PSA value more than 30 and was treated by so many people, and they advised him that immediately you should undertake the surgery, otherwise your future may be in danger. And he was from a well-educated family also. After that, he went to one of the senior most homeopath doctor, but even after taking that, the PSA is not improving. So he was much frightened in those conditions, and people used to say that, oh, your condition is not getting improving. Like that. The patient was mentally depressed. But when he came to me, that what I found that he was a typical arsenic patient, then there is no need of going into any particular specification that it is a case of prostate. It can be a case of prostatic cancer, or it can be a case of a prostatic prostatitis or something like that. But I stick on with the medicine, and then what we find that the patient was feeling better. He day by day he improved. His physical conditions, everything improved, and he used to walk here and there without. He used to, when he visited me, he came with the family, total members of the family, and they want to know what to do, doctor. Whether we should go. We have taken this much of homeopathic treatment, so whether we will have to go for surgery or do something. The patient was frightened hearing that surgery. So I told him that there is no need of going back. Let us wait and see how it works. And actually, in those conditions, it works beautifully. And thereafter, the patient improved so much. And after 2 years, I asked, in between the PSA come to nearly 8.5. Then I told him that better if you want to stop the medicine, you can stop, or if you want to continue the medicine, you can continue. But he continued for one more year, and then he stopped in between. And because I told him that you just stop the medicine and you walk freely, then he used to come to my clinic in cycle. In though usually he come with a car with one of the cousin brother. So that much, even still he is living, and there is no problem with his prostate. So that means that if you stick on with the right remedy, it will work.
Yeah.
No need
Yeah.
of getting frightened that it can be a case of cancer. You need to, if the person went to surgery, definitely he may not be alive still, because that much of right was there in the mind of the patient. So this is what I would like to add. If anyone want to participate, yes.
Yeah. Thank you, sir, for the explanation. Yeah.
Yes, I invite Dr. Manoj to say a few words. Please unmute. Yes.
Thank you, Dr. Sanesh, and congratulations, Dr. Edison, Sergeant Edison. And the dynamic presentation, we need persons like you. And of course, we know that what happens if you prescribe a medicine for fever, definitely temperature will come down. Just like that, the pathology should also be rectified. Otherwise, we can't expect that the medicine is it was a medicine, not a remedy. So if you administer a remedy, definitely that will also, there is no doubt of that. But what is more important is give some advice on diet and regimen also. That's very important. Otherwise, it will act as an obstacle to the recovery. So diet and regimen is also important. Then, of course, the emotional disturbances is a major cause. Often after 50 or 55 years, a lot of financial problems, family problems, this problem, that problem, all this will together causing some sort of frustration in these patients, thereby developing these prostate problems. Along with the prostate problem, patients are often prone to develop some cardiac problems also. So this is a vital organ that gives the energy to the person. It makes a child to a male, to a man. So when it regresses, naturally problems will also likely develop. That's my.
Yes, now Dr. Najib can add something more to that. Okay.
Thank you, Dr. Tanesh, Dr. Manoj, Dr. Edison. When it comes to the dilemma of PSA, it was highly a kind of gold standard in the early days of PSA when it has been postulated. But later years, it came as a sort of consensus that PSA is not that important when unless it is otherwise correlated with clinical picture. You can have a PSA, high PSA with a benign, with a less risk of cancer, and you can have high cancer proliferation with a comparatively low PSA, vice versa. So PSA doesn't carry the value which was carried during the early days. It has been postulated. So that is, and for homeopathy, for us, we have a wonderful thing for everything. We have Herring's laws. We have most important thing we evaluate when we treat a patient is sensations and functions. This is remarkably important for me and the clinical picture. If it is okay, and we don't have to worry about the lab or pathological values, and pathological value will come down by its due course. That is my take in that. Thank you.
Exactly, that's what we will have. You are absolutely right, Dr. Najib, and this is what every homeopath need to look into and think in that way. Dr. Indrani Pavakkar, you want to add something more, I think?
Yeah. Sir, actually, just small addition I will do. PSA is an inflammatory marker tumor test, basically. And what I have observed in many patients having autoimmune disease, they have their raised interleukin 6 or their TNF alpha levels, and body is prone for autoinflammation. And because of this autoinflammation, PSA always remains high. And we think that the patient is going towards malignancy and the patient is not doing well. So according to Hahnemannian principles, we should look at the patient and not the lab figures. Because after some time, like Dr. Dhanesh sir mentioned, after some months, not in some days, automatically the levels they start coming down.
Exactly.
And you also mentioned very nice that we should not focus only on PSA. It is a misguiding level. So that is a take-home message for all.
Exactly, Dr. Indranil. Exactly.
Okay, sir. Thank you. Thank you for giving opportunity to ask a question. Yeah. Thank you.
Definitely. This is a forum where we are encouraging juniors as well as seniors to present their papers, as well as we will add something more to that if at all necessary. And if the person required help also, we will do, because this is how homeopathy can survive. We have seen that this Sajan has even he is the first year student in MD, but still he has the courage to come out here and made such a brilliant presentation about this article, this subject, particularly a big subject also. Dr. Ambrose, sir, do you want to add anything more?
Thank
You are
you,
muted.
Dr. Manoj ji and Dr. Dhanesh ji and everyone. Namaskar. Very nice presentation, Dr. Sajan ji. Many kinds of the medicine, enlargement of prostate gland. Prostate gland above age 50 years old suffer from prostate enlargement. According to miasmatic, role of miasmatic, according to homeopathic, treat the patient, not the disease. Symptomological, banish the symptom and relieve the patient. लेकिन according to miasmatic, thuja is a very good remedy, enlargement of prostate, and canthrid 3x या 6 power, very good remedy, and ecudiatum hilum, drop by drop urination. So very thanks, Dr. Sajan ji. Thank you, sir.
Thank you, Ramprasad sir. It was from Mr. Abdul Salam sir has brought this Sergeant Edison to this forum for this presentation. So you can say something more on that.
Thank you, Dr. Sajan. Very nice presentation.
Thank you,
Okay.
sir. Thank you.
Come again
So-
also.
So it is the time to wind up the session. I invite Dr. Najib Muhammad to say a vote of thanks to the session.
Thank you, Dr. Dhanesh. And when it comes to Mr. Dr. Sajan's presentation, it was crisp, clear, and very comprehensive. He has attacked the subject. He has attacked the pathology from all the weapons, like from the Department of Anatomy to physiology, bacteria, everything he has used in dealing with the topic. He has extensively covered, and most importantly, has covered the topic with materia medica very extensively. He has covered very, in a very decent way, has presented materia medica part. And of course, it was as if, as somebody said, as if we are listening to a assistant professor in our classroom. I felt something like that. So thank you so much, Dr. Sajan, for coming up with a topic, and you did a very good research on this. And thank you so much for, and I thank you on behalf of International Forum for promotion of promotion of homeopathy, and all who are assembled here, who are listening to you. I thank you once again for this wonderful presentation. Thank you.
Thank you, Dr. Najib Ahmad. Thank you, Dr. Sajan Edison, and those who attend the session. Tomorrow we will have a session from Dr. Sunil Raj, and Doctor will be talking about management of fever with its therapeutics, homeopathic therapeutics. So hope all of you will be here joining tomorrow at the same time. You can use the same thing. We will upload the videos of the presentation tomorrow by evening. So those who missed the session can watch it again. You can share it with your friends without paying any money. Please do everything for promoting homeopathy. Thank you all. Good night. It's over to Dr. Mariamma John to moderate the Malayalam session.